Everyone plays a role, even from early stage disease all the way to advanced stage disease. And having someone help navigate patients through that very complex system is important.
That's Paige Griffith, an oncology nurse practitioner from the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center. You'll hear more from her up next. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Most patients with biliary tract cancer are diagnosed at an advanced stage, and they face numerous challenges in getting care. That's why it's so important to build a multidisciplinary team that streamlines care and ensures patients receive more coordinated and effective support. First, we'll hear from Chaundra Bishop, a patient with biliary tract cancer.
So I was initially diagnosed at the age of 29, and to say it was a shock is an understatement, because at 29, you never expect to hear that you have cancer, especially one this kind of rare. So it was shocking. It was, scary. Everything was unfamiliar. There was a wide range of emotions, but there was also a little bit of hope, because they said, "Oh, you're young. Your body can, withstand the things we're going to throw at it to fight this disease." So despite all the big, scary emotions, there was a little glimmer of hope too.
What happened after you were diagnosed?
Immediately after the diagnosis, things started moving so quickly. I went in for, testing and biopsies and all of that to see what kind of cancer it was and what kind of chemotherapy I should take. And so things felt like it moved pretty fast. I was diagnosed in June, and then by the end of July, I was already starting chemotherapy. And so it was chemotherapy for about 8 months, and it was not as terrible actually as, TV or media makes it out to be. It was bad, but it was not as terrible. I was able to continue to work full time. My work schedule was, flexible with my chemo schedule. So it was definitely still quite the journey to go through, but it was not as harrowing as I thought it was going to be.
How has your cancer journey changed throughout the years?
When we first started, it was a lot about the first line care. And at that time, almost 9 years ago, there weren't that many options for care. But now if you look at treatments for BTC, the category has grown tremendously, where you have a lot of options. And so I think that that is something that is very exciting. And I get to sit down and talk to the doctor about more options versus them telling me that, "Oh, this is, the only thing that we have for you." So I think that that has been a tremendous change, where we can talk about different opportunities or different pathways I can take in treating this cancer.
Let's talk about your first line treatment. What was that experience like?
Actually, first line treatment wasn't too bad. I didn't lose my hair. I didn't lose all the weight that most people think is associated with cancer treatment. It was actually, as I said before, not that bad. I did have some, nausea, things like that, but nothing that secondary meds couldn't help. But there were really no issues in getting the meds or staying on the meds for that time. And eventually, while on the chemo, my tumor began to shrink, and it shrank to a point that it became operable.
Did you ever face challenges to getting care and support?
No, actually, I didn't have any issues signing up for the medication, and there was always social support available through the doctor's office, which I was grateful for, because, being so young, there weren't many people around me that had gone through anything like this. So it was nice to be able to have someone to talk with about what I was going through.
What did it mean to you to have a whole care team of professionals involved in your treatment?
That was one thing I was not expecting the multidisciplinary team that I received in chemo care or in cancer care in general. I thought it was just going to be, my doctor, my nurse. But again, like I said, there was social worker, there was palliative care doctors. It was incredible to see them all being able to work together on my behalf to make sure I was as, quote unquote, comfortable with this process as possible. And that was amazing to see because you often think, doctors are, sort of in competition with each other. But it was great to see that they could work together to, find the right, combination of things for me. It felt good to have a process or a regimen catered specifically to me.
What else would you like to say today, Chaundra?
From the patient perspective, I think it's always important to ask for what you need or ask questions if you don't understand something. Don't, as they say, suffer in silence. There were times where I was experiencing a side effect where I just thought, oh, I just have to deal with it. But no, you don't just have to deal with it. There are other treatments or adjustments and things that can be made so that you don't have to suffer, basically. I think that's very important from the patient perspective.
You heard from Paige Griffith at the start of the show. She's here to walk us through the medical oncology perspective of biliary tract cancer.
So there's a lot of layers to that. With patients with biliary tract cancer, it's often difficult to diagnose up front because it has a lot of vague symptoms. It could be some vague abdominal pain, slight weight loss, nothing that jumps out to you as significant up front, but then it progresses over time. It's a very rare cancer, so people are also not familiar with it. So if you present with certain symptoms such as rectal bleeding, for example, that triggers primary care, which are much more familiar with colon cancer, for example, to recognize those symptoms. But a vague abdominal pain, sometimes slight weight loss, epigastric pain, these things don't necessarily trigger further workup. And unfortunately, by the time often patients are diagnosed, typically with imaging, often in an ER setting, they are more advanced stages, which is some of the challenge with treating this cancer. Also, there can be difficulty with getting tissue or getting a biopsy sample. So the bile ducts are very small. They run throughout your liver. Most people actually don't know the role they play or how small they are or where they are in your body necessarily, but they're a small tree-like system that drains bile out of your liver. And the cancer often forms starting in the bile duct, but then it spreads into the liver. But if caught in an earlier stage or early in diagnosis, when you're trying to get a sample of the very friable bile duct, it can be hard to get a sufficient biopsy sample that yields a cancer diagnosis. And so people can have multiple procedures, typically an ERCP, where they use a camera and they go through the GI tract. People will need multiple of them to yield enough tissue that shows a cancer diagnosis, which then also delays treatment, the plan, and so on. Another complicating factor with this disease, specifically with biliary tract cancer, is because the tumors form in the bile ducts that drain bile out of the liver. If you have a tumor that's blocking the bile duct from draining, people's lab work, often their bilirubin on their labs and their liver enzymes, get very elevated, and they need a lot of interventions with things like internal stent placement to try to get the bile to drain out of the liver. And people can have a lot of complications with these blockages, with infection from all of these procedures. That it sounds like a lot, but they're some of the very few of the many complications that patients with biliary tract cancer have from diagnosis and then as they get into starting treatment.
Can you talk about the increased importance of biomarker testing?
Absolutely. So, in regard to bile duct cancers specifically, we know that they have a higher number of targetable mutations than many of the other GI cancers, specifically that we treat. So, about 40% of patients diagnosed with biliary tract cancers have a biomarker or molecular testing that yields additional treatment options. And so, when we're looking at a cancer that in the advanced stages has on average about a year survival, you add additional layers of therapy based on their molecular testing results. For example, IDH1 mutations or FGFR2 mutations. These have additional therapies in addition to the standard chemotherapy options that we have that can lead to prolonged survival, better outcomes, maybe being able to be downstaged to be able to have additional procedures such as surgery, for example. And some of the targeted therapies for these mutations actually can yield really significant response rates from treatment, up towards the 40% response range, which compared to the chemotherapy options, that's really promising for patients and they're generally well tolerated too. So that's getting into more treatment tolerance, but they add additional treatment options. We understand more about the biology of the cancer. And the more testing we do, the more things we also are learning about the cancer in time, and more treatments are being developed as we understand more about it.
How do multidisciplinary teams play a role in the complete care of these patients?
That's a great question because these patients are very complex all the way from diagnosis all the way through their treatment. And we have our standard of care treatments. If you have a very early stage biliary tract cancer, typically surgery is the standard of care. However, as we learn more about the biology and then the ultimate path of these cancers, they have high recurrence rates, for example. Having as many professionals who understand this cancer from a medical oncology perspective, interventional radiology perspective, nursing, social work for managing all the complexities, all the way up to radiation oncology, surgical oncology. Everyone plays a role, even from early stage disease all the way to advanced stage disease. And having someone help navigate patients through that very complex system is important. So having routine meetings where all of these professionals are coming to discuss the care of each patient, getting on the same track, discussing the most up-to-date data on management is important to provide the best care, but also even push the limits, I think, of what some of the standard treatment options can do.
Do you have any examples you can share that made a difference for a patient?
Sure. So we in Baltimore at Johns Hopkins have a center that sees a high volume of biliary tract cancers. And so where does that come into play? We have a lot of patients who are diagnosed in the community, which is where most patients live. And then they get referred to Johns Hopkins for a second opinion. So we have patients, maybe they've only met with surgical oncology in the community. The surgical oncologist may feel that this is resectable, for example, but they come to Johns Hopkins for a second opinion first. They come to our multidisciplinary clinic and they see our surgeons, but they also see medical oncology and interventional radiology. And we see some other high risk features. For example, high tumor markers or some suspicious looking lymph nodes that are nearby and look involved that often lead us to considering chemotherapy before going to surgery with the hopes to reduce the risk of recurrence after surgery. We also have clinical trial teams at our multidisciplinary clinics, or may there be a clinical trial option. So we have multiple patients that come from the community that we open up additional options for them when they're reviewed on a multidisciplinary level. May radiation be a better option with less morbidity than surgery for somebody who has a very small tumor and they may not need to go to the OR. So having additional disciplines, I think, gives people more options, but also can intensify and tries to push the limit of how successful each step of the plan can be.
Thank you to our guests today. We have more resources available in the show notes. While you're on your podcast app, tap the plus sign to follow the show. Until next time, for the Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Cancer Care Centers.